Welcome back to the deep dive. We're here to, take really dense clinical stuff and make it stick, make it actionable.
Exactly.
And our mission today, it's very focused. We are diving deep into endocrinology. So if you're gearing up for a big assessment, maybe the ACT exam, or you just want to get a solid handle on adrenal, thyroid, diabetes, well, this area is absolutely crucial.
It really is.
We've got this great stack of clinical notes here, really packed with the essentials, the diagnostic numbers, the dosing, the management warnings that really define high-stakes GP work.
And that's the heart of endocrinology, isn't it? It demands that precision. It's not just like learning symptom lists.
Yeah.
It's about understanding the connections, the feedback loops, the pathways. One hormone goes off kilter and the ripple effect systemically is huge. And the presentation, often frustratingly vague.
Yeah, definitely.
So our aim here is to flag those absolute must-know rules, especially where management is about a quick, maybe life-saving response, like, say, the adrenal sick day rules.
Yes, critical.
Or where it's those exact numbers, those cutoffs that separate one condition from another. We're aiming for systematic mastery here.
Sounds like just what's needed. Okay, let's get into it. Let's unpack this source material, starting with the adrenal glands. Tiny organs. But wow, they regulate stress, salt, sugar. They throw up some really acute challenges in endocrinology.
Absolutely. And to make this immediately practical, clinically useful, we need to draw that clear line, between the two main parts of the adrenal gland.
Okay.
The source flow chart we have is pretty helpful here. You've got the cortex, that's the outer bit, the steroid factory, basically.
Right.
Producing cortisol, that's stress, glucose control, aldosterone for salt and water, and androgens.
Got it. Cortex. Cortisol, aldosterone, androgens.
Then you've got the medulla, the inner core. That's your catecholamine center, adrenaline, noradrenaline, your fight or flight stuff.
Okay.
And pretty much every condition we'll talk about now maps directly onto too much or too little of one of those hormones.
That structure really helps frame it. Okay, let's start with the deficiency state, one with potentially deadly consequences. Adrenal insufficiency or Addison's disease, the condition of the lows.
Yeah, Addison's. It's high stakes because, as I mentioned, the presentation can be so nonspecific. Fatigue, weakness, weight loss. It could do anything.
Sure.
But the lab work, the specific tests, they are definitive. Diagnosis really hangs on two key things, that initial 9 a.m. cortisol level, and then, for confirmation, the short Snackson test.
And the notes give us these absolutely vital cutoffs to remember. These are crucial, especially for exam purposes. If that 9 a.m. cortisol is over 500 nanomoles per liter.
Unlikely. Addison's is very unlikely at that level.
Right, that's your exclusion number.
Yeah.
But flip side, if it's low, like below 180 nanomoles per liter.
Then Addison's becomes really likely. That triggers the next steps, like the Snackson test. These numbers are just gold for triage in primary care.
Absolutely. They anchor your thinking.
They do. And beyond just the cortisol, you look for that classic clinical and biochemical picture. Often you'll see hypotension, low blood pressure, combined with hyponatremia, that's low sodium, and hypoglycemia, low blood sugar. But here's the bit, the physiological twist that gives that non-intuitive electrolyte shift, which is a massive clue for you as a GP trainee. It's all about the lack of aldosterone.
Okay, explain that why again. Why does low aldosterone, the sold hormone, give you high potassium? It feels backwards.
It does feel backwards, but aldosterone's job is to tell the kidney, keep sodium, get rid of potassium and hydrogen ions.
Okay.
So when aldosterone is low, the kidney just doesn't get that signal properly. It doesn't ditch potassium efficiently.
Okay.
So you end up keeping potassium, leading to hyperkalemia while you're losing sodium. So it's that specific combination. Low BP, low sodium, high potassium. That's the hallmark of primary adrenal insufficiency. You see that, you think Addison.
It's like the whole saltwater system just stalls. The sources also mention some other, maybe less common, but still important blood findings. Things you might just stumble across.
Yeah, exactly. Sometimes picked up incidentally. Things like eosinophilia, maybe some anemia, leukocytosis, even slightly abnormal liver function tests, LFTs.
Right.
These might pop up during a workup for something else vague, but if you see them alongside that electrolyte pattern, low sodium, high potassium, alarm bells should be ringing loud and clear.
Definitely pieces of the puzzle.
Precisely. But look, knowing how to diagnose it is one thing. Knowing how to manage it, especially in a crisis, that's where it gets really practical for the GP trainee. We have to master the critical sick day rules.
Yes. This is absolutely non-negotiable knowledge.
It's literally life-saving. And the notes are clear. This must be taught, documented, reinforced every single time with every patient on hydrocortisone replacement.
Okay, let's spend a bit of time here because getting this wrong,
Hmm.
well, the consequences are huge. Standard treatment is replacement, hydrocortisone, and fludrocortisone.
Mm-hmm.
What's the exact plan when things go wrong, when they get sick?
Right. You have to grade the stress level. For just minor illness or stress, a cold, a bit of a fever, maybe up to 38 Celsius, a minor dental thing,
Okay.
the patient needs to double their usual hydrocortisone dose. Or, more specifically, take an extra 20 milligrams of hydrocortisone straight away, usually split through the day.
Just 20 milligram extra for minor stress.
Yes. That simple bump is vital. It mimics what the body would naturally do.
And what if it's more serious?
Right.
Or if they can't keep anything down? Vomiting.
That's the immediate escalation point. Vomiting, diarrhea, they must call a doctor straight away. Oral meds aren't getting absorbed, right?
Right.
They're heading towards an acute adrenal crisis. And if help is delayed or if they're becoming unresponsive, collapsing, that's the absolute emergency protocol.
The injection.
The injection. They or their family need to be trained and ready to give 100 milligrams of hydrocortisone intramuscularly, IM.
100 milligram IM.
It's a massive steroid dose to stabilize them immediately. That emergency kit needs to be accessible, instructions clear, family knows what to do. Knowing when to go from that 20 milligram oral bump to the 100 milligram IM jab that prevents circulatory collapse, it saves lives.
That is such a clear, vital escalation pathway.
Oh.
Okay, so moving from the lows, let's talk about the highs. Adrenal excess syndrome, starting with Cushing's syndrome, chronic excess cortisol.
Cushing's, yeah. This gives us one of those really classic textbook clinical pictures, though sometimes it can be misleading. It's all driven by that relentlessly high cortisol.
And you get the very visible signs.
Exactly. The fat redistribution, that characteristic moon face, the central obesity, maybe the buffalo hump on the upper back.
But the sources remind us cortisol's impact is way broader than just appearance. It hits almost every system.
Totally systemic. Yeah, you look for hirsutism, irregular periods, oligomenorrhea, metabolic problems like osteoporosis, brittle bones. Mood changes can be severe, like depression. And clinicians have got to remember the less obvious stuff, too, like chronic hypertension. And even things like chest pain from a spontaneous rib fracture because of that underlying osteoporosis.
Wow, so it's not just cosmetic. It's genuinely destructive systemically.
It really is. Investigation usually starts with screening tests, like a 24-hour urinary-free cortisol collection. But, for exam purposes, understanding the diagnostic pathway, especially figuring out where the excess cortisol is coming from, that's key.
Right.
And that brings us back to the pituitary hormone, ACTH.
Okay, talk us through that causality clue. How does the ACTH level pinpoint the source? This is classic feedback loop stuff, right?
Exactly. Perfect feedback loop example. So if the extra cortisol is coming directly from the adrenal gland itself, maybe a little tumor, an adenoma in the cortex,
Okay.
then that huge amount of cortisol floating around correctly tells the pituitary gland, hey, shut down. It causes feedback suppression.
That makes sense.
So you end up with decreased ACTH levels. High cortisol, low ACTH. The pituitary is doing its job, being suppressed by the primary adrenal problem.
So high cortisol, low ACTH points straight to the adrenal gland itself.
Precisely. That's the adrenal source pattern. But conversely, if the ACTH level is high, that means either the pituitary itself is misbehaving, pumping out too much ACTH autonomously, that's Cushing's disease, usually a pituitary adenoma,
Right.
or maybe the ACTH is being made somewhere else entirely, ectopically, like sometimes by a small cell lung cancer.
Okay, so high ACTH means pituitary or ectopic source.
Yes. And measuring that ACTH is the critical step. It tells the surgeon whether they need to be looking at the patient's abdomen or their head. Fundamental difference.
Absolutely fundamental. Okay, switching hormones within the cortex. Now let's talk aldosterone. Conn's syndrome, or primary hyperaldosteronism.
Right, cons. This has a very characteristic combination that, again, every GP trainee needs to recognize. It's a cause of secondary hypertension, so high blood pressure. That's paired with hypokalemia, low potassium. That's either there spontaneously or very easily triggered, say, by diuretics.
So hypertension and low K plus area.
That's the pairing. The excess aldosterone drives the kidney to keep sodium and waste potassium, the key diagnostic test. A raised aldosterone to renin ratio.
Why that ratio?
Normally, if blood pressure is low, renin should be high to stimulate aldosterone. But in cons, the aldosterone is being pumped out autonomously by the adrenal gland, so it suppresses renin production. High aldosterone, low renin.
Got it. Autonomous production suppresses the upstream signal.
Exactly. Management, then, is either surgically removing the tumor, if it's a single adenoma, or using medication to control the blood pressure and block the aldosterone effect.
And the notes highlight spironolactone here.
Yeah, spironolactone is key. It's an aldosterone antagonist, blocks the receptor. But you need to remember its broader uses too.
Oh, yeah.
Well, blocking aldosterone systemically is also really useful for managing fluid overload and other conditions. Think ascites and liver disease.
Right.
And crucially, it improves outcomes in certain types of heart failure. So understanding its mechanism, blocking that receptor, lets you see why it works across different diseases. Useful drug.
Definitely good to connect those dots. Okay, we've covered the cortex pretty well. Let's jump into the medulla now, the catecholamine factory. Pheochromocytoma.
Yeah. This is where you get a tumor, usually in the adrenal medulla, pumping out massive amounts of adrenaline and noradrenaline.
Leading to?
Episodic or sometimes sustained severe hypertension. The classic presentation involves paroxysms, sudden attacks of headache, palpitations, sweating, though it can be less dramatic too.
How do you test for it?
You don't measure the adrenaline directly usually. You measure its breakdown products, the metabolites, so you look for plasma or urine metanephrines.
Well, metanephrines, got it.
Management is surgical removal of the tumor. But, and this is a huge but, a critical safety point, there is an absolutely non-negotiable medication sequence you must follow before surgery.
This is the alpha before beta rule, isn't it? Essential knowledge.
Absolutely essential. Life or death essential.
Yeah.
You must use alpha blockers first, something like phenoxybenzamine.
Okay, alpha blockers first.
Before you even think about introducing beta blockers like propranolol.
Why is that order so critical?
Okay, think physiology. The tumor spews out catecholamines. These hit both alpha receptors, causing massive vasoconstriction, clamping down blood vessels,
Right.
and beta receptors, speeding up the heart rate. Now, if you block the beta receptors first with propranolol, what happens? You take the brakes off the heart rate, sure, but you leave all those alpha receptors wide open and unopposed.
So all that adrenaline just hammers the alpha receptors.
Leading to catastrophic, unopposed alpha-mediated vasoconstriction. Blood pressure goes through the roof. You can precipitate a fatal hypertensive crisis, acute heart failure. It's disastrous.
Wow.
So it's always alpha blockade first, relax the blood vessels. Then, once that's established, use beta blockade to control the heart rate. Every single time. No exceptions.
Alpha, then beta. Got to burn it into my brain now. That's a critical management rule, anchored in physiology. Okay, let's shift gears entirely. Moving on to section 2, the thyroid, the body's thermostat. Let's start with hypothyroidism, underactive thyroid, defined by a raised TSH level.
Right, hypothyroidism. This is bread and butter GP work, huge volume. First step is figuring out the cause because they're quite diverse. We need to sort them into categories. Autoimmune, inflammatory, maybe drug-induced.
Okay, so autoimmune, the big one is Hashimoto's thyroiditis, right?
That's the classic. Usually presents with a painless goiter, maybe rubbery feeling. And you'll find positive TPO antibodies, thyroid peroxidase antibodies.
And then there are more sort of invasive or inflammatory causes.
Yeah, less common but important to know, like Riedel's thyroiditis. Very rare, this one. It's characterized by intense fibrosis. The gland becomes rock hard, fixed, sometimes mimicking cancer. Very distinctive.
Okay. Hashimoto's, Riedel's, what else?
Well, there's postpartum thyroiditis, which can happen after pregnancy. Drug-induced causes are important too. Amiodarone is a notorious one.
Ah, yes, the antiarrhythmic.
And of course, simple iodine deficiency, though less common now in many places due to iodized salt. Once you've diagnosed it, management is all about levothyroxine replacement. But, and this is key for the GP trainee, the starting dose isn't one size fits all. It has to be individualized.
Right. The notes really stress this. Standard range might be 25 to 50 micrograms, but there are immediate red flags that mean you start lower.
Correct. 3 main things dictate caution. Age and cardiac status are the big ones.
Okay, so how does age affect it?
Rule of thumb. If the patient is over 50, you generally start lower, maybe 25 micrograms. Younger than 50, they can often tolerate starting on 50 micrograms.
But the really critical one is heart disease, isn't it?
Absolutely critical. If the patient has any history of ischemic heart disease, angina, previous MI, heart failure, you must start low, 25 micrograms, very cautiously.
Why is that initial caution so vital with heart patients?
Because thyroid hormone cranks up the body's metabolic rate. It increases oxygen demand, heart rate, cardiac output. If you ramp that up too quickly in someone with dodgy coronary arteries or a struggling heart muscle, you can precipitate or worsen angina, push them into heart failure, or trigger serious arrhythmias. Atrial fibrillation, AF, is a big risk.
So start low, go slow, especially with heart disease.
Exactly. You titrate up very gradually based on TSH response, maybe every 4-6 weeks initially.
And thinking about those complications, you mentioned AF. The risks of overtreatment, giving too much thyroxine, are also significant, right?
Definitely. Overtreatment or even just being slightly suppressed TSH for a long time increases the risk of osteoporosis, making bones weaker. It can worsen chest pain or angina. And yes, that increased risk of atrial fibrillation is a major concern, especially in older patients. Getting the TSH into the target range is key to avoiding these.
So finding that sweet spot is crucial. What about physiological changes like pregnancy?
Pregnancy, yes, needs adjustment. During pregnancy, the body's demand for thyroid hormone goes up, so the levothyroxine dose typically needs to be increased, often by about 25 to 50 micrograms early on.
How do you monitor that?
Usually guided by TSH levels, checked frequently throughout the pregnancy, often every trimester or more. Need to ensure both mom and baby have enough hormone.
Okay. And routine monitoring after dose changes. How often?
Standard practice is to check TSH every, say, 2 to 3 months after any dose adjustment until things are stable and the patient is biochemically euthyroid. Once stable, maybe annually or 6 monthly is enough.
Are there any common drug interactions we need to warn patients about, things that mess up absorption?
Yes, a really common one, antacids.
Like calcium carbonate, aluminium hydroxide.
Exactly. Those common over-the-counter remedies, they can significantly reduce levothyroxine absorption if taken at the same time.
So what's the advice?
Patients must separate the doses, take their levothyroxine ideally on an empty stomach first thing in the morning, and wait at least 4 hours before taking antacids or iron supplements, actually. Otherwise, they can end up effectively underdosed, becoming hypothyroid again, even though they think they're taking their medication correctly.
4-hour gap. That's a really
Wow.
practical piece of advice for primary care. Okay, let's flip to the other side. Hyperthyroidism. Overactive thyroid, low TSH. We need to run through the differential diagnosis here, the different causes of thyrotoxicosis.
Right, several conditions can cause it, and they have some neat differentiating features, often involving inflammation markers like ESR and how the thyroid gland takes up iodine on a scan.
Okay, first up, true hyperthyroidism, like Graves' disease.
Yeah, Graves is the most common cause. It's autoimmune, driven by TSH receptor stimulating antibodies. Key features: ESR is usually normal, and an iodine uptake scan shows increased uptake. The gland is overactive, grabbing iodine to make excess hormone.
In treatment,
Usually involves antithyroid drugs like carbimazole or propylthiouracil PTU, especially in pregnancy planning. Plus, beta blockers like propranolol are great for controlling the symptoms quickly, the tremor, the palpitations. Radioiodine or surgery are options too.
yeah. Second cause, Crevaine's thyroiditis.
This one is different because it's inflammatory, often follows a viral illness. The absolute hallmark symptom, the big clue, is a painful goiter. The neck is tender.
Pain is the key feature.
It really is. Investigation backs this up. You see a raised ESR, indicating inflammation. Iodine uptake can be variable, often low after an initial spike. Management is about the inflammation and pain. NSAIDs usually do the trick. Sometimes steroids are needed if it's severe. It's usually self-limiting.
Got it. Painful goiter. Raised ESR equals de Quervain's. What else is on the list?
Well, you can have a toxic multinodular goiter or a single toxic nodule. Here, specific areas of the thyroid become autonomous, churning out hormone irrespective of TSH. Management often leans towards definitive treatment like radioiodine or surgery to remove the goiter or nodule.
Okay. And postpartum thyroiditis. We mentioned it under hypo, but can it cause hyperout too?
Yes, it often has phases. It can start with a hyperthyroid phase, usually within the first few months after delivery, sometimes followed by a hypothyroid phase later on. Key features: ESR is typically normal, and iodine uptake is usually low or heterogeneous. Often, just symptomatic treatment with propranolol during the hyperphase is needed, as it often resolves on its own.
Right. Often transient.
And finally, we have to mention amiodarone again. That drug is tricky.
Double-edged sword.
Absolutely. It's packed with iodine and can also directly damage thyroid cells. So it can cause hypothyroidism, which you treat with thyroxine replacement. But it can also cause hyperthyroidism, amiodarone-induced thyrotoxicosis, AIT.
And that's complicated.
Very. There are two types of AIT, type 1 and type 2, with different mechanisms and treatments. It's complex, often requires specialist input, potentially involving steroids or antithyroid drugs, depending on the type. Definitely one for referral if it causes hyperthyroidism.
Okay, so amiodarone needs careful thyroid monitoring, always. That covers the thyroid differential as well. Right, let's tackle the final section, and it's a big one, very complex. Diabetes mellitus. Navigating this management maze is absolutely central to GP training and practice.
Couldn't agree more. Let's start with a specialized area, but one where knowing the thresholds is vital. Gestational diabetes mellitus, GDM.
Right, diabetes in pregnancy. Timing and cutoffs are key here, aren't they? Because it impacts mom and baby.
Absolutely paramount. Standard screening is with an oral glucose tolerance test, OGTT, usually between 24 and 28 weeks of gestation.
But what if they've had GDM before?
Good point. If there's a history of previous GDM, the sources say you do an additional OGTT much earlier, right at the booking appointment, first trimester. You need to catch recurrence early.
Makes sense. And the diagnostic numbers, the cutoffs, they're different in pregnancy, lower than usual.
Yes, crucially lower. This reflects the tighter control needed to protect the fetus. So for a pregnant woman, a fasting glucose of 5.6 millimole or more is diagnostic of GDM.
5.6 fasting.
Yeah.
Compared to 7.0 outside pregnancy.
Exactly. And for the 2-hour post-OGTT value, it's often around 7.8 millimole or higher, depending on local guidelines, compared to 11.1 outside pregnancy. These lower thresholds trigger intervention much sooner.
Good to highlight those specific pregnancy cutoffs. Risk factors. Who's more likely to get GDM?
Key risk factors include ethnic background, particularly Afro-Caribbean, Middle Eastern, or South Asian descent. Also, previous GDM, family history of diabetes, obesity, high BMI, and older maternal age.
And management. It follows a clear ladder approach.
Very clear. First up is always lifestyle. Dietary advice from a dietitian, exercise, aiming for a BMI below 27 if possible before pregnancy, or managing weight gain during.
And if lifestyle isn't enough,
then metformin is the first-line medication, generally safe and effective in pregnancy.
when do you have to escalate to insulin? What's the trigger for that?
Insulin comes in if glucose targets aren't met with metformin and lifestyle. Specifically, the notes mention, if fasting glucose stays at 7.0 millimole or higher, insulin is needed.
Okay, fasting 7 or more.
Or even if fasting is a bit lower, say between 6.1 and 6.9, but it's combined with evidence of complication like the baby getting too big, suspected macrosomia, or too much amniotic fluid, polyhydramnios, then you also move to insulin straight away. It's about protecting the pregnancy outcome.
Got it. Control needs to be tight. Okay, let's move to a more niche type, but one GPs need to recognize, MODY, maturity onset diabetes of the young.
Yes, MODY. Important not to misdiagnose this as type 1 or type 2. It's defined as diabetes diagnosed relatively young, usually under 45, often with a very strong family history running through generations. But crucially, these individuals typically don't have the features of insulin resistance you see in type 2 and often lack the autoimmune markers of type 1.
And there are different genetic types.
Several types, yeah. The notes mention the most common one is caused by a mutation in the HNF1 alpha gene, known as MODY3. Interestingly, this specific type is sometimes associated with non-diabetic things like renal cysts.
So suspect MODY, strong family history, young onset, no typical T1, T2 features.
Yes.
What's the workup and management implication?
Genetic testing is mandatory to confirm the specific MODY subtype. This is vital because the management can be drastically different.
How so?
Well, for MODY3, for instance, these patients are often exquisitely sensitive to sulfonylureas, drugs like gliclazide.
The ones that stimulate insulin secretion.
Exactly. They can often manage perfectly on low-dose sulfonylureas, sometimes even coming off insulin if they were incorrectly started on it. So, getting the diagnosis right avoids unnecessary insulin. Inheritance is autosomal dominant, hence the strong family history.
Fascinating. Getting that diagnosis right really changes management. Okay, now on to the more common types. Type 1 diabetes, T1D.
Right, T1D typically presents younger, often with quite dramatic weight loss. They are dependent on insulin right from the diagnosis. And we must always remember, the first presentation can be severe. Diabetic ketoacidosis, DKA, a medical emergency.
Definitely. How do we confirm it's type 1? Monitor it.
We look for the evidence of autoimmune destruction of the pancreatic beta cells. The key markers are antibodies, anti-GAD antibodies, islet cell antibodies. We can also measure C-peptide. This reflects how much insulin the patient's own pancreas is still making.
And what happens to C-peptide over time in type 1?
It declines. Initially, there might be some residual insulin production, the honeymoon period, but over time, usually within about 5 years, the beta cell destruction becomes complete and C-peptide levels become very low or undetectable.
That confirms the insulin dependence. Education is massive in T1D, right?
Absolutely fundamental. Patients need structured education. The notes mention DAF&E dose adjustment for normal eating. It's a widely used program, certainly in the UK.
What does DAF&E teach?
Essentially, it empowers patients to match their rapid-acting insulin dose to the amount of carbohydrate they eat for each meal. It gives them flexibility and helps achieve better control.
And what sort of blood glucose targets are we aiming for?
Generally, the target capillary glucose level is between 4 and 7 millimoles before meals, but targets need to be individualized, of course.
Now, this leads to a really critical area for GP trainees managing T1D patients' drug interactions. Lots of common drugs can mess with glucose control, can't they?
Hugely important. This requires real vigilance. There's a significant list of drugs that increase blood glucose levels.
Like what? Give us the main culprits.
Steroids are a big one. Prednisolone, for example, causes insulin resistance. Glucose levels will shoot up.
Okay, steroids.
Certain antipsychotics can too. Immunosuppressants like tacrolimus and cyclosporins, even some common diuretics, furosemide, thiazides.
Wow, even thiazides. So if you start someone on insulin on, say, bendroflumethiazide for blood pressure,
You need to anticipate their glucose control might worsen and they might need insulin dose adjustments. You absolutely have to review the whole medication list. It's non-negotiable.
that interconnectedness is so important to grasp. Is there another major pharmacological pitfall in T1D?
Yes, beta blockers.
We mentioned them with FIO. What's the issue here?
They mask the warning signs of hypoglycemia.
How so?
Well, when blood sugar drops too low, the body releases adrenaline. That causes the classic hypo-warning symptoms: tremor, palpitations, sweating, anxiety.
Right, the adrenergic symptoms.
Beta blockers dampen down that adrenergic response. So the patient might not feel those early warnings. They could slip into severe hypoglycemia without realizing it's happening, delaying treatment. Very dangerous.
So extreme caution with beta blockers in T1D. What about self-monitoring rules? How often and how do they adjust doses?
General guidance is monitoring at least 4 times a day, before each meal and before bed. More if needed, like during illness or exercise.
And dose adjustment.
The notes mention a simple 10% rule as a basic principle, often taught in DAFME. If glucose readings are consistently high before a particular meal, you typically increase the dose of insulin that acts before that meal, you go through the previous rapid-acting or basal dose, by about 10%.
And if consistently low?
Reduce the relevant dose by 10–20%. It's a starting point for self-adjustment, obviously needing refinement with the diabetes team.
Makes sense. Treatment is insulin, obviously. Can metformin ever be used in type 1?
Sometimes, yes, although T1D isn't primarily about insulin resistance. If a patient with T1D is also overweight or obese, say BMI over 25, metformin can be added.
Why?
Mainly for potential benefits on weight management and maybe reducing total insulin dose slightly through mild insulin sensitization. It's an adjunct, not core treatment.
Okay. And side effects to watch for? Hypoglycemia is the big one?
Hypo is always the main risk with insulin. Also, lipodystrophy changes in subcutaneous fat at injection sites, either lumps, hypertrophy, or dense atrophy. Rotating injection sites is crucial to prevent this.
And managing hypos. Depends on consciousness.
Absolutely. If conscious and able to swallow, fast-acting glucose is needed. Glucose tablets, sugary drinks, not diet, Rallo, followed by slower-acting carbs once recovered.
And if unconscious.
Medical emergency. Glucagon IM injection is the key intervention if available and someone is trained to give it. Otherwise, call emergency services for IV glucose.
Clear pathway. Okay, let's tackle the giant. Type 2 diabetes, T2D. And specifically, that complex treatment escalation pathway. This is core GP territory.
Absolutely. Diagnosis first, again, relies on those numbers. Fasting glucose, 7.0 millimole or higher. Random glucose, 11.1 millimole or higher. Or an HbA1c of 48 millimole, which is 6.5% in old units or greater.
Wait, the outline said HbA1c asymptotic or low. Let's stick to the source. Okay, let's use HbA1c of 48 millimole of 6.5% as the threshold. But note, 9C guidelines often use 48 as the diagnostic threshold, but might target treatment based on other levels. Let's assume the source meant 48 millimole, 6.5% for diagnosis, which aligns with WHO. If the patient is asymptomatic, you need to repeat the test, right?
Yes, repeat tests needed if asymptomatic to confirm the diagnosis and rule out, say, lab error or transient stress hyperglycemia. HbA1c is generally preferred if available as it reflects longer-term control.
Okay, diagnosis confirmed. Treatment pathway starts with?
Lifestyle, always. Diet, weight loss, physical activity, that's the foundation. If that's not enough, the first-line medication is typically standard-release metformin.
Start low. Go slow with metformin.
Usually, yes. Start with 500 milligrams once or twice a day, increase gradually every week or two, up to a max of 1 gram twice daily, to minimize those common GI side effects like diarrhea or nausea. Modified release, MR metformin can help if standard release isn't tolerated.
Okay, metformin first line. But the pathway branches early now based on other health issues, particularly heart disease.
Yes, this is a major change in recent years. If the patient has established atherosclerotic cardiovascular disease, like previous MI, stroke, peripheral artery disease, or is at high risk, for example, based on QR risk score, or has heart failure or chronic kidney disease, CKD,
Then what?
then an SGLT2 inhibitor should strongly be considered early on, often alongside metformin, or even instead of metformin if it's contraindicated or not tolerated.
Okay, explain the why for SGLT2 inhibitors again. Why prioritize them for these high-risk patients?
Because drugs like dapagliflozin and empagliflozin, they do more than just lower glucose by making you pee it out. They have proven significant benefits in reducing cardiovascular events, MIs, strokes, hospitalization for heart failure, and also protecting the kidneys, slowing the progression of CKD. These benefits seem to go beyond just the glucose-lowering effect.
So it's cardiorenal protection.
Exactly. So if that risk profile is there, you bring them in early. If there's no high cardiovascular risk and metformin is contraindicated or not tolerated, then the alternative first-line options are usually a DPP-4 inhibitor like sitagliptin, pioglitazone, or a sulfonylurea like gliclazide.
Okay, so first-line choice depends on CV risk profile and metformin tolerance. What triggers moving to dual therapy?
Escalation happens if the HbA1c isn't at target after about 3 months of monotherapy. The target HbA1c for intervention is often around 58 millimole, 7.5%, according to NICE-E, though the outline used 5.8. So let's clarify. NICE guidelines often trigger intensification if HbA1c rises to 58 millimole, 7.5%. Let's use 58 millimole, 7.5% as the trigger point for adding a second drug, aligning with common practice.
Okay, HbA1c hits 58, 7.5%, despite monotherapy. Time for dual therapy. What do you add?
You add a second drug. The choice depends on what they started with, and again, comorbidities and patient factors. If they started on metformin, you could add a DPP-4 inhibitor, pioglitazone, a sulfonylurea, or an SGLT2 inhibitor, if not already started for CV risk.
Lots of options.
It's about tailoring. For example, if weight gain is a concern, you'd probably avoid pioglitazone and sulfonylureas. If avoiding hypos is critical, you'd avoid sulfonylureas. If they have CV risk, SGLT2I is preferred.
Okay, makes sense. And if dual therapy isn't enough, if HbA1c is still 58, 7.5% or more after another 3-6 months,
Then you move to triple therapy, add a third drug.
how do you choose the third drug?
Again, based on what they're already taking and individual factors. Common combinations are metformin plus DPP-4I plus SU, or metformin plus PO plus SU, or metformin plus SGLT2I plus DPP-4I, or metformin plus SGLT2I plus SU.
The notes mentioned a specific rule about dapagliflozin in triple therapy.
Yes, it said dapagliflozin, an SGLT2I, is only added to a metformin plus sulfonylurea combination. That seems quite specific, possibly relating to older guidance or specific trial data. Current practice might be more flexible, but it highlights that some combinations are more established or studied than others. We should probably note that NICE guidance often recommends metformin plus SU plus SGLT2I, or metformin plus SU plus pioglitazone, or metformin plus DPP-4I plus SGLT2I as common triple therapies before considering insulin, reflecting the evidence base.
Okay, complex combinations. What about the GLP-1 agonists? Where do they fit in? Like semaglutide, liraglutide?
They typically come into play around the triple therapy stage, or sometimes even earlier if weight loss is a major goal. The guidance often recommends considering a GLP-1 receptor agonist if the BMI is high, say 35 or greater, or maybe BMI 30-35 with other weight-related comorbidities.
Why specifically for higher BMI?
Because they are very effective at promoting weight loss alongside improving glucose control, they increase satiety, slow gastric emptying. That weight loss can be a huge clinical advantage in obese T2D patients. They also have cardiovascular benefits demonstrated for some agents in the class.
Okay, so GLP-1s are an option, especially if weight is an issue. What's the final step if triple therapy, or maybe dual therapy plus GLP-1, still fails to control HbA1c?
The final step is usually escalation to insulin-based therapy.
Straight to insulin. Or is there an intermediate step?
The outline mentions an interesting intermediate consideration. Before jumping to insulin, if triple therapy fails, consider switching one of the drugs to a GLP-1 agonist if BMI is over 35, or if BMI is lower, but weight loss or occupational factors like driving regulations making hypos particularly problematic favor avoiding insulin initially.
So trying a GLP-1 before insulin in certain cases.
Yeah, it acknowledges the benefits of GLP-1s and the desire to delay insulin if possible, especially regarding weight gain and hypo risk associated with insulin. However, if the patient is already on insulin, the advice is usually only add a GLP-1 agonist after specialist consultation.
Right. And initiating insulin itself, that requires careful consideration.
Absolutely. Starting insulin in T2D is a significant step. It often involves starting with just a basal, long-acting insulin once daily, maybe continuing metformin alongside it. It requires careful patient education on injection technique, hypomanagement, blood glucose monitoring, and potential impact on driving. DVLA notification is usually required in the UK. Specialist advice is often recommended, especially for complex regimens.
This whole T2D ladder, it's incredibly structured but complex, trying to balance glucose control, CV risk, weight, hypo risk.
It is, and it's constantly evolving as new evidence emerges for different drug classes.
Before we wrap up T2D, any final caution? You mentioned sulfonylureas.
Just to reiterate, sulfonylureas, like niclazide, are effective and cheap, but they carry a significant risk of hypoglycemia.
Why?
Because they stimulate the pancreas to release insulin regardless of the blood glucose level or food intake. This risk is higher in the elderly, those with irregular meals, or renal impairment. Patients need explicit warning and education about hyposymptoms and management if they're started on an SU.
Good reminder.
Okay.
That brings us towards the end. We have covered a huge amount of ground today. Really detailed stuff on adrenal, thyroid, and diabetes management.
We really have. It's been quite a journey. From the acute side of things, like those adrenal crisis sick day rules.
Yeah, the 20 milligram extra for minor illness, the critical 100 milligram IM for crisis.
And understanding why low aldosterone gives you that high potassium, that hyperkalemia, that link is key.
Definitely. Then we navigated the thyroid, those subtle levothyroxine starting doses, remembering to start low, 25 milligrams if there's any heart disease, to avoid worsening angina or triggering AF.
And clarifying the differences, like the painful goiter in Dicravanes versus the autoimmune picture in Graves's.
And finally, diving deep into diabetes, the specific lower cutoffs for GDM diagnosis, like that 5.6 fasting glucose.
Right. And unraveling that complex T2D treatment ladder, knowing when to bring in SGLT2 inhibitors for cardiorenal protection, when GLP-1 agonists are favored for weight loss, and understanding the risks, like beta blockers masking hypos in T1D or SUs causing hypos in T2D.
Those specific numbers, those cutoffs, the 500 cortisol to rule out Addison's, the 180 to make it likely, the 5.6 fasting GDM threshold, the HbA1c 48 diagnostic level, the 58 intensification trigger. They are the high-yield facts you need to move forward confidently.
They really are anchors in clinical decision-making.
This deep dive, I think, has given a really systematic, practical overview.
Yeah.
Moving beyond just theory into how you actually apply this in primary care, especially with exams in mind.
Absolutely. It's all about patient safety, efficient diagnosis, and effective management.
So before we finish, let's leave you, our listeners, with a final thought. Something to chew on as you consolidate all this. We talked about how many really common medications, things GPs prescribe every day, like thiazide diuretics, furosemide, prednisolone, can significantly raise blood glucose. They can throw a stable diabetic patient off course, or even unmask diabetes in someone susceptible.
Yeah, it happens all the time.
So, given that complexity, the sheer number of potential drug interactions across all three systems we discussed, adrenal, thyroid, diabetes, here's the question. What systematic process, what routine check could you as a clinician build into your daily practice? Something to make sure you never miss a critical drug-induced endocrinopathy when you're reviewing a patient's medication list, especially when adding something new.
It's about designing your own safety net, isn't it? Connecting those common prescriptions to these less common but potentially serious endocrine side effects. How do you make that check automatic?
Exactly. It pushes beyond just knowing the facts to thinking about robust clinical safety systems. Food for thought. Right. That's all we have time for in this deep dive. Thank you so much for joining us as we navigated these endocrinology essentials. We really appreciate you tuning in.
Thanks, everyone.
We'll catch you next time on The Deep Dive.